Good evening, everyone. I am Lorraine Govender. I'm the National Manager for Health Promotion at the Cancer Association of South Africa. Today's melanoma webinar, titled Let's Get Under the Skin of It, Melanoma Mutation Matters, is brought to you by Novartis and the Cancer Association of South Africa. Skin cancer is the most common cancer in South Africa, with about 20,000 reported cases every year and 700 deaths per year. Looking at the statistics in South Africa, research that was conducted between 2005 and 2013 indicated an overall 11,784 invasive melanoma cases reported to our National Cancer Registry. The overall incidence of melanoma for South African males is 51%, mainly in the areas of the limb and trunk. Among these stats, almost 875 Black South Africans were also diagnosed in the public sector with melanoma of the limbs. The incidence among females is almost 68%. In both males and females, the age group is mainly below 61. So yeah, it is affecting everyone, and it's not only a cancer for the aged. Lower limb lesions remain one of the most important areas that is picked up by many of the people. I just want to check whether our first speaker is here this evening.
I think Dr. Govender is running a bit late, so we'll proceed as discussed earlier.
Okay, thank you so much. So this evening, our plans includes a talk by an oncologist. I will give you the title soon. However, our first speaker, since Dr. Govender is running a bit late, we will move over to our patient, our melanoma patient, Catherine Berger. Catherine is 40-something, living in Joburg. She is married with one daughter who is in first year at varsity. After teaching senior high English and speech and drama for many years, she has gone into adult education and training. She has been an instructional designer, learning manager for an American company for the last 10 years. Catherine's passion is the bush and wildlife, and she escapes to game reserves all over Africa whenever she can. Catherine was diagnosed with stage 3B melanoma on the 21st of July, 2016. After 2 years of different treatments, she has been almost cancer-free for nearly 6 years now. I will now hand you over to Catherine to give us her talk on her journey. Thank you.
Everybody, thank you so much for having me on this webinar. I can't believe how many people are on here. And yeah, I'm just very honored to be invited, and I know that quite a lot of people from the Melanoma Support South Africa are online here, and I know quite a few of you now, just by voice or whatever. So hi, and nice to meet you, so to speak. Yeah, so I think everybody's cancer journey is very, very personal. It's very painful. And it doesn't mean that because I've had this cancer journey that you know, it's any different from anybody else's cancer journey. I think we all have, you know, the same heartache that goes with it. I think that my journey is quite lovely and remarkable in that it just offers a lot of hope. I'm alive 6 years later. When I was diagnosed, there wasn't actually a lot of hope for this disease. I was diagnosed with stage 3B with a lymph node actually here in my epitrochlear node. It was kind of one of those nodes that kind of flares up and you don't know what to do. So you go to your GP, obviously, and the GP says, oh, it could be a lot of things, maybe an infection. Yeah, let's give you a course of antibiotics. And I had my course of antibiotics, but this node just didn't go down. It actually kept on getting bigger, and it was actually very painful. And, you know, a lot of people say, oh, well, a cancerous tumor isn't painful. Well, that's rubbish. I think it was sitting on a whole lot of nerves. And my GP started to get alarmed. I think the second time I went back, I had a scan of it, you know, an ultrasound, and it showed, you know, it was what they call a reactive node. Now, a reactive node could be a million things. So she just said, you know what, I think we should just biopsy this because it's not going away. Go to a surgeon. So I go to the surgeon, and the surgeon's now not at least bit alarmed. She thinks I've got something weird and wonderful called, when you get, you actually can get tuberculosis outside of your lungs. It's called extrapulmonary tuberculosis. She thought that that's what was the case. I was just going to need a lot of different antibiotics. So she went in and she said, let me just remove the node because it's big and it's painful. Let's just remove it. So she went in and she removed it. But she still didn't think. She thought a lot of other things could be wrong. She saw that none of my other glands were up. And I had never had a melanoma before. I'm one of those people who has what they call an unknown primary. I had things cut out of my body before, but they'd all come back benign. They'd all, and I don't have a lot of moles. I've got very fair skin. I've got the blue eyes. I fit the mold. But I've got lots of freckles, but I've got no moles. So when it came back that I actually had advanced melanoma, it was one of those, but knock you over with a feather. She had been so positive. And you know what it's like. I think a lot of people on here know what it's like. In the course of a week, you kind of go from, thinking life's okay to this absolute sheer inexplainable terror, where you have a PET scan. I ended up having a brain MRI, liver scans, you name it. I had it, met my first oncologist. And in those days, it was only 6 years ago. So the whole new, wonderful, wow, immunotherapy that's come about that is saving everybody's lives wasn't actually, it was around. It was obviously being used overseas, but it wasn't a thing in South Africa. Only if you had stage 4 could you maybe get onto that old one called Yervoy or ipilimumab, and you could get onto that, but you'd have to pay. You literally would be paying cash 1.5 million rand for a course of treatment. Medical aids were not even thinking about it. So I was put on something very old and archaic called interferon. And some people on this group must probably did do interferon or know about interferon. It's just the most terrific, toxic thing you could ever do in your life. You have to inject yourself 3 times a week for a year. And literally minutes after you've done the injection, you start going into convulsive chills, having a full-blown fever every time. And it was highly toxic. It made me feel so ill, or just 1,000,001 side effects and symptoms. And I knew at that point that I wasn't actually going to make it through the year, just having done like 2 months or whatever. And I think what's wonderful about social media and the internet, and when I was diagnosed, and I actually see him on this group, Peter Hers was the only person I could chat to, because I contacted CANSA and I said, I've been diagnosed with this, and I just don't know who to talk to. I don't know anything about this disease. And they put me in touch with this lovely gentleman who I see in Hello Peter. I'm glad to see you well and still cancer free. And he gave me so much hope, because in those days, I think that was 6 years ago, he had been cancer free for already 10 years. And I think he had done interferon. And he gave me hope that there was hope for this disease. But the more I Googled, the more I looked it up. In those days, your prognosis was not so good at stage 3. You were just literally, oh my word, there's pictures of me on the thing now. But literally you were going to try this interferon that didn't work. It actually had the most ridiculous, success rate. It had no success rate. And you were going to do this and just hope that it was going to, get better. And it wasn't helping people. And in fact, now they don't use interferon at all anymore, because they've realized it was just not worth using. But anyway, going back to, I think I digressed there. What happened was that I started doing a lot of research, and I went onto social media and came across a whole lot of American groups of people with stage 4 and stage 3, busy, going through these all brand new immunotherapies, wondering why I couldn't get onto one, because in South Africa, they weren't offering it for stage 3. For stage 4, you could get something. And obviously there were clinical trials around, but I didn't qualify. So I found on one of these sites, it's called Melanoma United, some people might be on that group, that there was this South African gentleman at a different oncologist who was on something called a compassionate access to a drug that's widely used now. It's kind of the twin of Keytruda, and I'm sure Keytruda is going to be mentioned by Dr. Govender just now. But a lot of you know what Keytruda is, especially if you're on treatment, if you've been on treatment and I know that this talk is about mutation. I'm BRAF negative, so there wasn't actually much on offer for me. I could never do targeted treatment. So I found out that this one oncologist, who is obviously now my oncologist, had this access to compassionate use of this drug. And I was very lucky to get onto his trial for stage 3 patients. I ended up doing 37 infusions of adjuvant therapy. Have been cancer-free, hopefully. I think so, since actually when I had the node removed. They did go back in and remove the second node, just, to be on the off chance. It never actually spread to my axillary nodes under my armpits, where everybody thought it would spread to. But I was just incredibly blessed that I think the surgeon got it all. So I did this adjuvant therapy to prevent it from coming back. And thank God it hasn't come back. And I was actually supposed to do a full 2 years of this treatment, because that was the original protocol. I know that everybody here knows now that you do a lot less or fewer treatments of Keytruda or whatever other treatment you're on to see if it's going to be curative. But in those days, it was supposed to be 2 years. I was supposed to have 52 infusions every 2 weeks. The drug I was on, Optivo, which is, like I say, very similar to Keytruda. It was a 2 bi-monthly protocol, so it wasn't every 3 weeks like Keytruda. And yeah, I did okay on it. I eventually had to give it up after 37 infusions because of side effects, but those side effects were much better than what happened to me with that horrible interferon. And also it saved my life, and I think that everybody knows who's been on immunotherapy here that it does give you niggles. It definitely has side effects, but they tend to be more chronic. Most people know that they're autoimmune related, and eventually, I think my oncologist got tired of how sick I was becoming, and he said, let's just can this. And so I've go for annual PETs now. I was going every 2 years, and I graduated last year at 5 years, where I know they never say that you are totally free, or they don't use the word remission with melanoma. As you know, they use the word NED, no evidence of disease. So I've been no evidence of disease for many years, but my oncologist did use the remission word last year at my 5-year checkup, saying, well, he doesn't think it's going to come back. So I'm very blessed. And because of that, I feel that I just want to help people. I have started, I'm one of the admins of a online cancer support group, Melanoma Support South Africa. I know quite a few of you are on it. If you're not on it and you'd like to be on it, it's a Facebook group. Please join. We just try to give each other support. We're not doctors. We don't give medical advice, but it is basically just giving each other support, especially in those early stages of horrific diagnosis when you just don't know what to do or where to turn. And that's where I was at. And that's why I so desperately wanted to start something or to help people, because I just found that the people just didn't understand it. And people still don't understand it. I'm sure that most of you out there are fully aware of the fact that, when you explain to somebody you've had melanoma, they think you've had this tiny little mole that's been removed and you're absolutely fine and hunky-dory and whatnot. And people are still actually oblivious to the fact that it can kill. It's highly aggressive. It's a horrible, horrible beast, as we know. And it's just, I suppose, our main message out there is just to make sure people are sun smart. And it's still sad how few people are still actually not sun smart. If you go to the beach these days, you still see people just basking in the African sun, just there to kill them. So I obviously, and weirdly, I've never really liked the sun. I've always been pale. And like I say, I'm very freckly, and every time I've gotten to the sun, I just got more and more freckles, which I hated. So yes, I don't know. We don't know where my primary was. So you know, we can presume it was somewhere on my forearm before the node. But yeah, so I don't know. I think I'm waffling now. I'm willing to. I don't know. People want to ask questions. What's the story? What else would you like me to say, Lorraine?
Thank you, Catherine, for sharing your journey. And I think today there are a lot of patients as well, and your story is one of hope. And you also touched on something quite important, which is the support. Um, you know, when you have cancer, and I think they say 20% is the treatment and 80% is your support structure when you're going through your cancer journey. And yeah, I think you've touched everything. I'm not. If there are any questions, everyone is welcome to please post it on the chat box, and Catherine will definitely respond. Any comments, you're welcome to just write it on the chat box. We are mindful of time, and we know it's evening and it's usually supper time, so we don't want to take up too much of everyone's time. But Catherine, thank you. Thank you for your message of hope and for the time this evening. And you are right. You know, when we find patients and when we see patients, it's often this misunderstanding. Oh, it's a small, tiny little piece, and you know, it's not really something serious. But the stats that I shared earlier on definitely touches on the fact that we lose lives through to melanoma, and it's not something that we need to easily, you know, just say it's just something else and put it, just go easy on it. Definitely not. Thank you, Catherine. I will now go over. I think our oncologist is here with us now, Dr. Puveen Govender, and I'm just going to read a short bio on him. Thank you. Dr. Puveen Govender completed his undergraduate studies at the University of Natal in 2000. He obtained his fellowship in radiation oncology from the College of Medicine of South Africa in 2008. Thereafter, Dr. Govender completed his Master of Medicine in Radiotherapy and Oncology, MMed, through the University of KwaZulu-Natal in 2011. He then received his certification as an oncologist from the European Society of Medical Oncology, ESMO, in 2012. After stints at the clinic as the clinical head of oncology at Nkosi Halbert Lutuli Central Hospital in Durban, and as acting head of HOD in the Department of Radiation and Oncology at the University of KwaZulu-Natal, he ventured into private practice in October 2016, joining the OncoCare team. Dr. Govender is on the editorial committee for the South African Journal of Oncology and serves as a postgraduate examiner with the College of Radiation Oncologists. He has multiple publications in peer-reviewed journals. He enjoys reading, music, and yoga in his spare time. And I would also like to add, he is a huge support structure to the Cancer Association of South Africa. And there has been many times when I've needed to knock on his door for help, especially with advocacy and lobbying efforts. Thank you, Dr. Govender. I hand you over now.
Good evening, everyone. Thank you, Lorraine, for that kind introduction. Emmanuel, I think you'll put up our slideshow. So I'd like to touch on some of the exciting evolutions in the treatment of malignant melanoma. And it was interesting listening to the previous speaker regale her experience with interferon. Certainly it was a drug we used without much success, but with certainly lots of toxicity. So I have to say we're on firm footing in terms of making groundbreaking inroads into the treatment of melanoma with immunotherapy and targeted treatments. Next slide, please. So melanoma is a readily curable cancer with 85% of cases enjoying long-term survival followed by surgery. And I think that's important to bear in mind, and it speaks to the fact that early detection is critical when it comes to melanoma. If you do have any moles and it does exhibit any worrisome features, it's imperative that you get it looked at immediately. I think world over, there's been a dramatic increase in the incidence of melanoma, especially in countries like Australia, South Africa, North America. And when we look at the risk factors, you can appreciate that it's primarily in countries with significant sun exposure. And as I said already, it's become one of the most rapidly evolving fields in cancer research over the past years. I still recall the Helicon days when we used to use drugs like dacarbazine and temozolomide to treat advanced melanoma with only a modicum of success. And now that we have better guns in our armory, the challenge remains acquisition of these drugs, both in the private and the state healthcare sectors, primarily because they are quite cost prohibitive. So we all know that when it comes to cancers, we talk about the often remarked 4 stages, stage 1, 2, 3, and 4, with stage 1 being the earliest and stage 4 being the most advanced. And what you can appreciate from the slide that's before you is the fact that stage 1 undoubtedly has the best prognosis as compared to stage 4, where historically we had a 5-year survival rate of approximately 20%. Next slide, please. So how do we prevent melanomas? For me, it's important that people understand what are the worrisome features and get them looked at regularly. Mole mapping is critical in terms of prevention, as is wearing sunscreen, wearing broad-brimmed hats, trying to avoid peak sun exposure between the hours of 10 to 2, and avoiding tanning beds as well. So these are simple things that we should all take cognizance of, especially those that like to spend time out in the sun, playing sports, etc. We have a lovely climate here in this country, and we tend to enjoy outdoor activities, but it's really important that we take these things to heart. So in terms of risk factors, we know that Caucasians undoubtedly have a high risk of developing melanomas. And certainly we see a lot of melanomas in countries where there's significant UV exposure. Other risk factors includes a personal or family history of melanoma, fair skin, blue eyes, history of sunburns, and having a large number of moles, that is more than 50. So these are the new ABCDEs pertaining to melanoma. And it's important that those of you that do have moles are au fait with the worrisome features. The A stands for asymmetry, and as you can appreciate from the pictures on the left and the right of your screen, the lesion on the right, you can see that there's the one half doesn't match the other half. Irregular borders are also associated with high-risk features. Variegation in the color, where there's no uniformity in the color, that's also another important warning sign, as is the case with a diameter that's more than 4 millimeters. Evolving means if it suddenly starts becoming itchy or bleeding or elevated, lifted off the skin, that's also another worrisome feature as well. So it's very important to know your ABCDEs when it comes to melanoma, because it's critical in helping us with early detection. So let me take you through the processes that we go through as clinicians. So oftentimes, if you do detect a worrisome nevus and you go through to your primary healthcare physician, they will take a history and they will look at the lesion. And if they think it's worrisome or suspicious of a skin cancer, remember melanoma is but one of many types of skin cancers. The reason we're talking about melanoma as opposed to the other types of skin cancers is because the squamous cell and the basal cell skin cancers tend to have a better prognosis and a lower propensity to spread to other parts of the body. Hence, they have hence our focus on melanoma, which tends to be more associated with blood-borne spread. So if your clinician feels that melanoma is suspicious for cancer, he or she would undertake a biopsy, and a biopsy means to take a piece of tissue and send it off for testing. The pathologist will look under the microscope and give us insights into whether he thinks it's benign or cancerous. So we work on a staging system, as we've alluded to, the stage 1, 2, 3, and 4. But to get to that we have to look at 3 parameters. We refer to it as T and M staging, where the T stands for tumor, N stands for nodes. Colloquially, we refer to that as lymph glands, and M stands for metastases or blood-borne spread. That referring to spread to other organs. So usually melanomas are skin cancers, and they can, however, spread to organs such as the liver, the lung, the bone, and the brain. So how do we determine the thickness? So when that biopsy specimen gets to the pathologist, he or she looks under the microscope, and they can tell you how many millimeters it is under the microscope. It's what we call the Breslow's thickness. And obviously we know if it's less than 1 millimeter, it's what we call a thin melanoma. If it's more than 4 millimeters, it's what we call a thick melanoma. And as you can appreciate, the thicker the melanoma, the more ominous the outcome. So usually with the thinner melanomas, surgery on its own suffices in the way of management. If it's a thick melanoma, there's a high propensity for spread to the lymph glands, and oftentimes we would have to do a procedure where we sample a lymph node to see if there's lymph node spread. So how do we check for lymph node spread? As I said, if it's a thin melanoma, less than 0.8 millimeters, we wouldn't do a lymph node biopsy. But the recommendation is that if there's any melanoma more than 0.8 millimeters, we should do a sentinel lymph node biopsy. Sentinel comes from the Latin word centri, which means guard. And we know that each lymph node basin has a guard lymph node. The first draining lymph node in that basin is a sentinel lymph node. So what we do is we inject a blue dye around the melanoma and track it to its lymphatic plexus. In the slide before you, you can see someone with a melanoma on the abdominal wall, and there's 2 potential lymph node drainage sites. One is to the left groin and the other is to the left armpit. So we would track the blue dye to the left groin and to the left armpit. We would make cuts in those areas, see which gland stains blue, have a pathologist sitting with us in theater, passing on the gland to the pathologist, who would look under his microscope in theater. If there's no cancer, then we're comfortable and we can close up and needn't have to remove any more glands. If that gland is positive, then certainly that would be a worrisome feature. Historically, this was always a case where if that one gland was positive, we would do a formal lymph node drainage where we remove more than just that gland. But modern thinking is just removing that one gland is adequate because it's more prognostic and it helps us with staging and planning further treatment. We haven't found a survival benefit from doing lymph node dissections in melanomas as we would get in breast cancer, for instance. Next slide, please. Then looking at distant spread, we alluded to this already as well. We said that the common sites of blood-borne metastases are to the liver, the lung, the bone, and the brain. So we can do imaging studies, CAT scans, PET scans, and that will be left to the clinician to decide which would be the most appropriate imaging modality to look at all these organs and ascertain whether there is or is not spread via the bloodstream. So there we go. You can see in the picture before you, when you look at the epidermis, and then you can see that for stage 0, it's the tumor is confined to the epidermis. But as we progress down the line from stage 0 to stage 4, the thickness is obviously more pronounced when you get to stage 2. Stage 3 implies spread to the lymph glands, and stage 4, they're spread via the bloodstream to other organs. Important to bear in mind, can you just go back, please? Important to bear in mind that all cancers up to stage 3 fall within the realm of potential cure. Stage 4 is a little bit different. Our treatment intent for stage 4 melanoma is what we call palliative or control-based treatment. With the ushering of new treatments such as immunotherapy, there are a handful of cases where we've managed to achieve cure even in patients with stage 4 disease. So the treatment options for small melanomas, surgery is by far the gold standard. And it's important that the surgery is performed by someone who's au fait with melanoma resections. It's well known that you need at least a centimeter rim of normal tissue when you're cutting around a melanoma. So we call it margins, and there needs to be adequate margins because that reduces the risk of relapse. Sometimes if there's a big defect when you're cutting around a melanoma, when you're getting a large margin, there can be quite a big defect. There might need to be a skin graft done or free flap, in which case the surgeon may rope in a plastic surgeon to help him cover up that defect. So for early stage melanomas, as I said, surgery is usually curative, and there may not be any need for any add-on treatment. The medical term we use for add-on treatment after surgery is called adjuvant treatment. So that's an interesting concept because there has been lots of exciting new data for patients after surgery, especially patients with high-risk disease profiles. For melanomas that have gotten into the lymph glands, we spoke about the sentinel lymph node biopsy, and the additional treatments that I'm speaking about in that slide refers to two important modalities of treatment, one being targeted therapy and the other being immunotherapy. For targeted therapy, patients who've had surgery and have been noted to have stage 3 disease, if they harvest a mutation called a BRAF V600E-OK mutation, they are eligible for targeted therapy, and this is done for a 1-year duration. If they don't have a BRAF mutation, they may be eligible for immunotherapy, which differs from targeted therapy. Targeted therapy is oral treatment taken as a tablet in the comfort of your own home. Immunotherapy is done as a drip every 3 weeks, also for a duration of 1 year. So with regards to the targeted therapy, it's largely earmarked for patients with stage 3 disease. The recent data for immunotherapy has also validated its use for patients with high-risk stage 2 disease as well. So immunotherapy is a huge buzzword in oncology right now. 80% of the patients that come in my consulting room ask me about immunotherapy, and that discussion is not just for melanomas. They ask across the board. In truth, however, the most robust data we're currently seeing is in melanoma and lung cancer for now. And there's obviously accruing data in other solid organ cancers. So your body's disease-fighting immune system may not attack cancer because the cancer cells themselves produce proteins that help them hide from the immune system cells. And immunotherapy works by interfering with that process. I have to say that the side effect profile with immunotherapy is a lot more manageable than chemotherapy. It's a much more predictable. And basically, in simple terms, immunotherapy works by supercharging your body's own immune system to fight the cancer cells. Next slide, please. So I also alluded to mutations, and I think all of us are more familiar with the concept of mutations with the advent of COVID and the multiple mutations associated with the COVID infection. Likewise, we are becoming more personalized in our cancer treatments as well as we uncover more and more mutations. One of the important mutations in melanoma is what we call the BRAF mutation, which is found in approximately 40 to 50% of all melanomas. So normally, if you look at the cell, on the outside of the cell, you get growth factors that bind to the cell membrane. And if you have a BRAF mutation, it results in abnormal downstream pathways, which promotes cancer growth. So we've developed a drug that blocks that BRAF mutation, and that has helped us to improve survival for patients both in stage 3 and stage 4 melanoma. And the reason we're mentioning this to you is not for you to remember these pathways or these mutations, but it's more about understanding that we have made evolutions and bringing this up in your discussions with your clinician. Sometimes in certain sectors of our healthcare, predominantly the state healthcare system, we don't have access to these drugs. And it's important that even if you are diagnosed with a melanoma and they don't offer it in the state sector, discussing these options with your clinician, because there's also the options of clinical trials, which if one is eligible, can make these drugs available free of charge. So that's important to bear in mind. Next slide, please. So we also understand that melanomas has a high propensity for spread to the brain. In fact, 20% of patients are found to have brain spread at the time of diagnosis of stage 4 melanoma, and more than 50% develop brain spread during the disease. So that's quite a high percentage of patients. It's one of the disease entities where we recommend scanning the brain at the time of diagnosis because of the high incidence of brain spread. In fact, on some occasions, patients don't necessarily present with a lesion on the skin or a spot on the skin. They present with seizures, they manifest with seizures or confusion, and they rock up to the casualty. We end up doing a brain scan and we find spots in the brain. And then thereafter, on careful skin examination, we find an ugly looking mole. And biopsy the mole and gives us the answer that this is a melanoma that has spread to the brain. And oftentimes in those instances, we can use radiation. If there are widespread spots in the brain, we do what we call whole brain radiation. But if there are a few spots that are contained, that are less than 3 centimeters in diameter, there is the potential for a more specialized form of radiation where we can shape the beams to target that spot alone with minimal affectation of normal brain tissue. And that's quite different to the whole brain radiation that I alluded to earlier on, which, as the name suggests, hurts lots of normal brain tissue as well. And the long-term cognitive impact thereafter tends to be quite significant. So even with the radiation, we've also made lots of inroads. We've got more specialized forms of radiation, and that's also worthwhile chatting to your clinician about as well. So this is my last slide. And as you can see, the melanoma researchers certainly understand how sinister a disease it can be, how biologically aggressive certain melanomas can be. And that is why, as you can see, researchers are taking no chances. And likewise, us too should also limit sun exposure, take the necessary precautions, regular use of sunblock, broad-brimmed hats, etc. It starts with the basics. It starts with the basics, mole mapping. So these are important screening tools that we should adopt, important preventative measures we should adopt. And then in terms of the treatment that I've spoken about, I think the horizon is very bright. What we have to bear in mind in a South African context, as I said earlier on, is that a lot of these treatments are cost prohibitive. And one just hopes that in time to come, they become more accessible to the population at large. With that, I'd like to thank you for your time and attention.
Thank you, Dr. Govender, for a very, very informative presentation. I like the simplicity in which you explain things, and I know it must have been difficult for you because a lot of that is quite advanced. But I think you've touched on something very important, and the advocate in me comes out now when you spoke about medication in the public sector not being available to a lot of people. I think that there is hope in terms of the clinical trials that is available. So I think public sector patients can be mindful of that and also speak to their clinician, when they go in. But the Cancer Association is also working with the Cancer Alliance through the Access to Medicines program that we have. So we are lobbying and trying to push, for more ease in terms of the patent law system to have more of these drugs affordable and looking at alternative reimbursements as well. So thank you, Doctor. I think early detection is absolutely important. And when we talk to patients, in our care homes and when we come across them, they often say, I just thought it was just something small. And I never thought it was quite serious. I never paid attention to it until the pain starts. What is your opinion on when the pain starts? Is it more advanced at that time?
Yeah, so it's an interesting one. I mean, with melanoma, as I said, there's multiple potential sites of bloodborne spread. And I mean, if you get a melanoma that's advanced, would spread to the lungs and liver, then there wouldn't necessarily be pain. It's primarily when there's spread to the bones and you've got extensive bony metastases, that's when it's often associated with pain. So I think it's important to look at the context. Pain doesn't necessarily always mean, it's not always associated with stage 4 melanoma. It could manifest just with coughing, shortness of breath. Then you'd worry that, hey, hold on, this could be somebody with spread to the lungs. Patient that presents with jaundice that could potentially be spread to the liver. As I said already when I discussed radiation to the brain, patients can present with confusion and seizures. So it can take on protein manifestations. So for me, it's about knowing knowing your body. Your body speaks to you like a mother speaks to a child. Understanding the moles that you have, sometimes it's difficult to look at your back, get your spouse or your neighbor to help you. It's really important to be vigilant on the journey. Don't ignore things. I think, and that would probably be my critical take-home message for everyone. To know your ABCDEs, look at the mole. If it's changing in size, color, borders changing, rush to your clinician. And even if you want to be even more proactive than that, start a relationship with your dermatologist where every year you do a mole mapping. Once a year, you can look at the mole under magnification and he'll give you a better idea of whether there's sinister features or not.
Thank you, Dr. Govinder. I think, knowing your body is extremely important. And, when we talk about the ABCDE and of skin cancer and checking, we always say to people, to the public, just as a woman would do her self-breast examination, we also need to make sure that there is a lookout for the signs and symptoms and asking, a family member or someone close to you to check your back and other areas is important. Doc, there are some questions on the chat box. I'm not sure if you are able to answer them.
Yes, I can.
Thank you.
Let me read the question out for everyone. I have stage 4 melanoma and currently on the BRAF meds, which are working. However, medical aid funds for specialized meds have run out and they won't pay for more. How would one apply for the clinical trial? So I think if you are accessing the drugs in the private sector, I'm not sure if we have Novartis on the line. Are they around, Marilise? So I've got a patient in a similar scenario where she couldn't afford the co-payment. So in the private sector, depending on which medical aid tier you're on, you allocated a certain pool of funds. And usually with your garden variety medical aid, you normally allocated to approximately 200,000 Rand per annum. And with some of the bigger medical aids, once that 200,000 Rand is exhausted, you're liable for the 20% co-payment and the medical aid will pay the other 80%. So discuss with your oncologist about signing you up for a program called the AICF program. and that program will help with your co-payments. I'm not sure if Marlies wants to chip in as well.
Yes. Thank you very much, Dr. Govender. That's perfect. That's a perfect answer. Thank you very much. I would have said the same. Thank you.
Yeah, and thank you to Novartis. Thank you to MSD for creating these programs. You know, when you look at 20% of large sums of money, they can make it quite a huge hole in your pocket.
I think there's 2 more questions here, Doc.
Yes, let's have a quick quiz.
Would you like for me to read out for you?
I'm currently melanoma stage 3B since surgery in May 2020. I got diagnosed just after having a baby mole on my back. After having a baby, a mole on my back started growing and itching. Is there a link between melanoma and pregnancy? No, not to the best of my knowledge. You know, it might just have been purely coincidental. You know, melanomas are not hormone-related cancers, unlike breast cancer, where the concept of pregnancy-associated breast cancer is well known. With melanoma, there's no direct causative link between pregnancy and melanoma. So in my mind, that just is unfortunately very coincidental. When the phrase cancer-free is used so frequently, it's a bit confusing because they say there's no cure for it. And those cells are still in our body. So is it more that there is not trace of it as a tumor in our bodies? So we tend to use the word disease-free or cancer-free, which in a sense means what it says. By the English language, meaning cancer-free means that you've gone for your follow-up check. Your doctor would probably do an S100 blood test, regular scans, clinical examination, look at the body, take a proper history. And if after doing all of those things, there's no suggestion of any disease relapse, then the most appropriate term is in fact being cancer-free. And, you know, one can argue that after 5 years of being cancer-free, then you can perhaps use the word cure. We always say that the 5-year interval is usually when most relapses happen. So after 5 years, then, you know, you can definitely say that you are cured, but obviously the surveillance continues even after that 5-year window. If you are BRAF negative, can it change to BRAF positive? No. So it's unlike with breast cancer where you get change in your receptor statuses. With melanomas, there's no relationship where you can move from negative to positive. Are there currently any clinical trials for Keytruda and Yervoy combined? My husband has stage 4 and has spread to liver, lungs, bones. He's 38. He will get radiation on the humerus for now. Medically does not pay for the combination. They will only pay for Keytruda partially. Our doctor has recommended both drugs. Yeah, so, you know, first we started off with Yervoy. It's a drug called ipilimumab. It's what we call an anti-CTLA-4 antibody, also immunotherapy, works in a different pathway. And then you get drugs like Keytruda, Opdivo. These are drugs which you call PD-1 inhibitors. So they're different types of immunotherapy. They work on different ways to release the brake on the T cells. And recent clinical trial data suggests that a combination of anti-CTLA-4 and anti-PD-1 works better than anti-PD-1 alone. So that would be the gold standard. So as I alluded to earlier on, just to get immunotherapy on its own is challenging enough, both in the private sector and the state sector. So to try and acquire the combination, in my mind, unless you're on some top-notch medical aid plan, is exceedingly difficult. Are there clinical trials? Well, it's worth looking around. Usually the clinical trials are there until we prove the concept. And the concept that combining anti-CTLA-4 and anti-PD-1 has been proven already, So you wouldn't get too many clinical trials testing that same hypothesis unless it's looking at other PD-1 inhibitors aside from the ones we mentioned already. Right, there we go. So it
Thank you
seems,
so much, Dr.
sure.
Yeah. Thank you for your time. We know how important it is for you, and we really value everything that you've presented this evening. May you have a good evening. If there are any more questions, thanks. We will now move over, and I'm going to read a short bio. Our next speaker is, we're going to hear from the perspective of a carer. So we often don't hear from that. And I think this talk that we're going to hear now is extremely important. Dean Hodgson is a 42-year-old real estate entrepreneur living in Ballito since 2011. He is a proud father to 3 wonderful children, Jake, Hartley, and Brooke, who mean the world to him. And he owns Cornerstone Property Partners, working with like-minded agents nationally. In early 2016, Dean's mother was diagnosed with stage 4 lung cancer and passed later the same year. Dean's sister Claire had a cancer scare previously in 2019. And after the shock of their mother's death, Dean and Claire found out that she was diagnosed with stage 4 metastatic melanoma in 2018. Claire put up a great fight and as a result helped pave the way with medical aids for treatment options in South Africa. Dean is happy to see and learn, and there's been much progress and advances in terms of treatment options available to melanoma cancer patients from 2019. Thank you, Dean. I hand over to you.
Thank you, Lorraine. And just thanks to all of you on this webinar this evening. It's so fantastic to see so many people here and being able to share and learn. And a huge thanks to Novartis for giving me the opportunity to speak this evening, and also to the Cancer Association of South Africa, as well as a huge thank you to Dr. Govender for giving so much information, because as my sister said, and there's an article, if you look up Claire Hodgson and melanoma, you'll see she actually spoke about exactly what's been mentioned this evening, that Lorraine's mentioned and Dr. Govender, but how being in tune with your body could save your life. And it really is so important to know what's going on in your body for you to better understand what how you are. So I just wanted to say also, it's so fantastic to have an opportunity like this where people getting together to share information about melanoma. And I know for my sister and the media that she did, the support that it helped with other people and also paving the way for people to get medication and have some form of treatment. I know that initially that she wasn't able to get access to some of the drugs, but with the help of Novartis and Dr. Gary Sofa, was able to get access to dabrafenib and trametinib, which helped her. And in one of her articles, she talks about when actually starting on the medication, how it helped the tumors actually just started melting away, which is so fantastic to see. But I think for me, the biggest thing was caring for a sister. And my sister was very, very strong throughout the entire journey that she walked in her stage 4 when she found out she had cancer. But the biggest thing was the hope and positivity, the hope that she brought to the people around her, but also the hope that it was for me as her caregiver to help her along the journey. And I know that one of the biggest things was the advice from the oncologist and how important it is in terms of talking with your oncologist and getting the correct advice of what the next treatment option is. And it's exactly what some of you have asked about other opportunities in terms of getting onto a clinical trial. It really is important for you to speak to your oncologist about that. But I think the reality is, even as a caregiver and being a brother to a 35-year-old sister who had stage 4 cancer, was just the need that she needed, the support that she needed from me being on a daily basis to get her around, take her to a treatment, as well as then actually after having the treatment, the follow-up, and just being there as support to her was invaluable. And she just needed just to know that at sometimes that there was somebody there to love and care for her, and that everything was going to be okay. I think that obviously the correct advice from the doctors. And I know that when we walked this journey with her, we were in the process of looking for any opportunity for some sort of treatment that she could get. And because of that, we had spoken to our oncologist, as I mentioned already, spoken to our oncologist who gave us different forums of people to speak to. And I know that I've made notes here that my sister actually spoke to a gentleman, David, who was in the UK, who also had metastatic melanoma, and through the correct treatment process is a cancer survivor, which was fantastic to hear. And so obviously that gave keeping on in contact with people like that. And that's why this is so fantastic, seeing so many people on here this evening, that I really just hope that just by spreading the word and letting other people know to be in tune with their bodies, and to actually let people know that there's a support group out there, and there are so many individuals, and huge thank you to Catherine for sharing her story. So many other people, individuals and families afflicted by this disease, just to keep people up to date and let them know there's so much advancement in medication and treatment nowadays. I know that with Claire, as mentioned by Lorraine, that short bio that my sister had in 2009, she had a mole underneath her foot, and she had that removed. And unfortunately, 9 years later, it had become metastatic, but she didn't know at the time why she was feeling ill. I know that somebody asked about pain and things like that, but yeah, she didn't know why, obviously just from stress, and it had then metastasized and actually gone to other parts of her body. But I think the biggest thing was the care and the hope and the positivity. So for me, it was throughout that entire journey, just looking for the right treatment, but being the fun person I am, just to try and keep the hope and positivity that yes, there was always going to be another treatment option. There was something that we're looking forward to the next treatment, insofar as it was a step in the right direction to get to the point of wanting to be cancer free. And so we were always constantly laughing and joking of all the things that we were going to do. And it really was just keeping an active mind. And so that's why my sister, with that positive energy, wanted to assist as many other people to be aware of what you need to be looking out for. I know there's a few things that she talks about in one of the articles, and I see that somebody's talking about dietary tips. And I know that it's so important to have a good diet. And that was one of the things that I assisted with my sister. She wanted to make sure that she was following a strict routine, and she kept, between the two of us, we kept each other accountable, that she had meals throughout the day to take whenever she had her medication as well, but through that dietary requirements, that she was trying to be as strict as absolutely possible. And that also gave her the strength, just day by day, keep going, and you get things done. I know that it was quite a funny story, but I know that once you're on some of these drugs, you definitely don't want to go outside, but when you're sitting inside and you're cold some days, you go outside. I know she got unfortunately, she ended up back in the hospital the one day just because she had too much sun, just because she wanted to get warm for a couple of minutes outside, and ended up with terrible overheating. But I think for everybody here, obviously you're here for a particular reason, to either get more information. And I think for me, just as a brother and a caregiver to my sister, the biggest thing was, when you go to the oncologist, and it's a case of, I know my sister started writing just some information and saying what next. She wanted to write a book called What Next, because obviously what happens is you go to the oncologist, you get professional information from your doctor or clinician, and then you kind of, well, what next? Like, what are the next steps? And I think having people to talk to is so fantastic, like this, and speaking to other people where you can start. And I'm sure that those of you who've met other people along your journey, you keep in contact with those people and you become friends with those people, because those also become your support structure as a cancer patient. And the exciting thing is also to see those people as they progress, and those who obviously go on to get a lot better and also then become cancer free. And so I just urge you or implore you to speak to more people, to create a wider awareness of metastatic melanoma, and to make more and to help more people. I know that I wanted to just talk to you, but it was about being a caregiver. But through the journey that I walked with my sister, it was so rewarding to me, because I've seen how far, and I've kept abreast of some of the information regarding melanoma treatment, whether it be here in South Africa or internationally. And it's been interesting for me, it's been very rewarding to have helped a couple of people through this process, and actually go on, fortunately, go on clinical trials. And somebody just happens to be that I'd met through this process, through my sister, somebody by word of mouth, through some of the articles. We helped him get onto a clinical trial. He had actually recently moved to Belito, where I live, and was renting a property through our company nevertheless. And he's just recently moved overseas to the UK to be close to his family, but also to be able to get treatment. And so that's been a couple of years. So there's a lot that you can do for yourself and for other people out there, but just making them aware of this disease, and noticing early anything that might be going on in your body. So that's it from me. I hope it's been helpful, and yeah, wish you.
Thank you so much, Dean. It has definitely been helpful. But I would like you to also just give us a few tips. You know, often a cancer patient, they are quite vulnerable and they need support.
Absolutely.
And they often feel like they are a burden to their caregiver.
Yeah.
How do you deal with that? And I'm sure many of the people that are here listening now experience that.
Yeah, so I think, I can understand it from a patient's point of view, but I think to know that the people who are there to care for you, whether it be a loved one or even a professional person, to know that they are there and they've got your best interests at heart and they want to care for you. And I saw that even when, if it was not myself, professional caregiver as well that we had, they're definitely there to love and care for you, that really and truthfully. And it's certainly not a burden, because obviously you're walking a journey where you cared for.
Definitely. And, you know, you mentioned the resources, which is so important, even as a caregiver. You know, you don't have to fight that battle alone. There are so many other organizations and support structures that's available for you as a caregiver to help you to support that patient. And I think what we would want to say to everyone is, don't hesitate to include the bigger circle of friends and family that want to support you. I think those are important words, you know.
So, I mean, you're 100%. Thanks, Lorraine. And I think that's, you 100% correct. I'm talking about it now. And it's easy for me to talk about it because I've managed to speak to so many people openly about this. And that's been, for me, that's helped me as well. And having the support from other people. So yes, as a caregiver, yes, very important for you to share with other people and get support from others as well. So there's a few other
otherwise you're going to have
organizations
fatigue and then you're going to end up in hospital. Thank you so much. Thank you, Dean, for that encouragement, and continue the good work that you're doing. And I hope you do join our support groups as well as a caregiver. Thank you.
Thank you.
Okay. I think, the Cancer Association does provide, valuable screening. Dr. Govender even touched on the photo finder screening that is available. So before we will now play out with the video. Thank you so much.
Growing up, I was just a fun, very active child. I used to have problems when I was in the sun. We didn't take it too seriously. We just kept rolling.
I remember distinctly a couple of serious burns as a child. We fell asleep in the sun around the pool, so I didn't take care of my skin.
Melanoma is the most dangerous type of skin cancer. People who have severe sunburns in childhood in particular are at very high risk of developing melanoma.
What was skin cancer at the age of 7, 8. If anything, if you've ever heard the word cancer, it's really associated with white people.
Anybody can get a melanoma. Our typical patient is somebody with a light skin tone, often with red or light hair, blue eyes, sometimes a freckly skin as well. We should be checking our skins regularly, ideally monthly. Out of sight areas like the scalp and the buttocks, for example, too. The tricky thing is, of course, areas like your back. You may need a hand mirror or a committed friend or partner to help you with that.
We usually use the ABCDE to explain to people what to look for. So the A is for asymmetry. The one side of the mole or pigmented lesion doesn't look the same as the other one. The B is for the border. If it becomes irregular in the shape or even scallopy as it grows out, that would be abnormal. And then C is that the color of that mole or pigmented lesion or freckle is not uniform. And then the D is the diameter. If you think about the eraser on the back of a pencil, if it's bigger than that, but I think more importantly, changing in the size. E is for elevation or any evolution, so if the lesion becomes a little bit more raised, if it was flat before. And we usually add a F as well, which is for funny looking. So any lesion that looks different or unusual on your body.
I go into my neurologist for one final checkup. And I said to her, listen, I've got this thing on my leg. She looks at it and immediately says, hold on. I need to call the dermatologist.
When we're young, we think we're invincible. But when it happens, and you come face to face with a statistical message, you don't want to hear that then. Suddenly, life becomes precious.
Your results came back, we did the biopsy, and you have stage 3 malignant melanoma. Yeah, I don't know what that is. And he says, you've got skin cancer. Because my mind literally went straight to, so I lost my dad 3 years ago. This is my ticket out. For 6 months, from March to September when I got my treatment, I was getting in the car, I was going to the hospital, I'd get on the highway, halfway there, I'd turn around and go back home, cry. I knew I was causing more damage to myself. But my biggest fear was going through chemo. What are people gonna say? When they look at me, I'm not gonna have my beautiful, rich, thick, gorgeous black girl hair. You know, I don't wanna lose that.
I would never have thought that sunburn or sitting in the sun could have such far-reaching and silent impact on one's life.
Some melanomas are extremely aggressive and progress very rapidly within a few months.
So if we catch it in the very early stages, the chance that you will live for 5 years is more than 98%. If it spreads to your lymph nodes, your chance of being alive after 5 years is getting about 63%. If you have metastatic melanoma, then your chance for 5 years survival is about 20%.
For 15 years, my maths, I have been a cancer survivor. That's about 3 times the 5-year period that is quite critical when you get a diagnosis like mine.
We have very exciting new medications available for people with metastatic melanomas. In the past, we thought we can do nothing for you. If that drug can make you live 5 years longer, it gives you a 5-year good quality of life. You can see a grandchild growing up. You can see your own children growing up.
We've got a little 8-year-old. Matthew turned 8 yesterday. I want to get extremely old. I really do, because I want to see him grow old.
I got in contact with Lucy, and she advised me to get in touch with a Facebook group called Champions of Hope. Send a message in the group, and complete strangers are supporting me, telling me, young one, you have to go in. You're too young to let this thing defeat you. I could have changed my entire destiny if I hadn't made that call on the Friday to get in contact with cancer. So cancer literally saved my life.
I want to thank all our presenters, our stories from Catherine and Dean for sharing your journey with us. We really appreciate it. To Novartis for making this possible. Without partners, our messages will not be able to get onto the platforms that is so much needed in our country. As a national manager in health promotion, we watch the National Cancer Registry quite often, and we review it. And what I want to say to the public and to everyone here, melanoma is on the rise. It is now among the top 5 cancers among males, and it's not a cancer to be taken in lightly. We have seen firsthand the devastation of this cancer, so early detection is the key. Thank you so much. We will also share a slide now on our photo finder screening and where you can pick this up. Thank you everyone for your time. Have a pleasant evening further. Thank you.